And I want to thank, of course, the organization to invite me. I would have loved to be with you in Thessaloniki. I'm tired to stay in Marseille for months, but I'm very happy to be here with you. So I have to find my presentation, and I'm a bit sorry if this presentation will sound a little bit old-fashioned, but that's a topic that has been given to me. Rigid bronchoscope, when it can be used, I would have preferred when it has to be used, but I try to cover that. Just to remind that I have some conflict of interest with Novatec. Novatec, who is distributing a rigid bronchoscope with my name, which is produced by Storz in Germany. Sorry if I repeat a little bit what Nikos said, but I always think that it's important to remind one slide of history, and just to remind that, of course, the first bronchoscope were rigid till Shigeto Ikeda developed and created the flexible bronchoscope. And just in parenthesis, I heard that, maybe I'm wrong, but Nikos said that the WABIP was created by Henry Colt, but which is not true. It was created by Shigeto Ikeda, even though Henry Colt is a good friend of mine, and he did a great job in the WABIP, but it has been created in Japan, the WABIP. So why in the 60s, when Shigeto Ikeda, why didn't the rigid bronchoscope disappeared? Like the rigid instrument disappeared in the GI endoscopy. Why? Because in the past, for esophagus, some rigid endoscope were used. So why do we still use a tool from the 19th century? And this is what I would try to explain you. So, as I said, my presentation is a little bit old-fashioned. There is not a lot of evidence-based medicine on what I'm going to say. It's more expert opinion. But here you have listed the five main indication for rigid bronchoscope: foreign body removal, silicone stent insertion, and Nikos said something about that. And I would say all therapeutic procedures that has to be done in the airway, in my opinion. So rather than a big list of publication saying that the rigid bronchoscope is the instrument of choice in foreign body removal, just have a look at this video in a patient who inhaled a foreign body, and few flexible bronchoscopy were attempted to remove it, and with failure. And just in a few seconds, by putting the rigid bronchoscope in the airway, grabbing the foreign body with the forceps, and very easily you remove a bridge of teeth. And so, again, rather than big words, it's just this movie illustrates. And of course, I'm sure that if you want, you will find so many publications, above all in the pediatric field, about rigid bronchoscopy in foreign body. Then, and Nikos said it also, if you have to place silicone stent, rigid bronchoscopy is mandatory. You cannot escape from it. And silicone stents is, at least in Europe, because we've done a survey on airway stenting in Europe, silicone stent are the most placed in Europe, and I think probably in the world. And just because it's a local pride in Marseille, I'm sure that you know that the silicone stent have been created in Marseille, and the first one was placed by Dr. Dumont in 1991. So either the straight stent and the wide stent has to be placed with rigid bronchoscope, because it requires rigid instrument to be loaded and then inserted in the airway. So here in this slide you have two kinds of stent applicator: the TON from Novatec and the FR from FR. So silicone stent require rigid bronchoscope. Why? Because you see, when you place a silicone stent, you have to make the room. You have to enlarge the airway to make the place for the stent. And this is why rigid is important, because we use increasing diameter tubes to enlarge, like in this drawing, tracheostenosis. So by putting different tubes, then you make the room for the stent, which is inserted in the airway. So that's a technique we use for placement. And for removal, again, the rigid bronchoscope has to be used. And you see very easily at any time, you can grab a silicone stent in the airway, turn it 360 degrees, and just remove in one block the stent and the rigid bronchoscope, and this is, I would say, removal is probably easier than placement, and of course the control after. I would just say that rigid bronchoscope is mandatory for silicone stent placement, but I would also say that regardless the stent you place, even metallic stent, in my opinion, it's safer and better to use a rigid bronchoscope even for metallic stents. Then other indications, so therapeutic intervention in the airway, and the most frequent is malignant airway involvement. And you know that you have different kind of involvement. It can be strictly endoluminal, it can be extrinsic or mixed. And 30% of lung cancer patients present with obstruction. 30% is probably some. It's clear. It's probably less, and it's less now because of the switch from the squamous cell central carcinomas to the more peripheral adenocarcinomas. So the percentage of obstruction is decreasing, but it still represents a certain amount of patients. That's a prerequisite for a successful procedure, technical successful procedure. So the obstruction has to be proximal, meaning trachea, main stem bronchus, bronchus intermedius. The disease has to be localized, like here. You need to have functional bronchi and lung parenchyma behind the obstruction. You need a functional pulmonary artery in order to avoid dead space, and you need the patient to have a performance status enough to enjoy the clinical benefit of this obstruction. Because we are talking about rigid, the most frequent, I would say, the most efficient technique, in my opinion, to make this obstruction is the mechanical debulking. And this mechanical debulking is achieved by the tip of the bronchoscope, which core a big piece of tumor, like you can see here. The big piece of tumor is removed with a rigid forceps. You see it on the gauze, and after you see the base of the tumor. And this mechanical debulking can be assisted either by laser or by electrocoagulation or argon plasma coagulation, whatever you want. If you are successful, whatever the technique, that's the goal is a success. Again, if you have all the prerequisites, the technique has been described. What has to be expected for as a result for interventional bronchoscopy? Immanual debulking in close to 90%, lung function improvement. Benefit duration is about 3 months, and survival improvement is probable because, of course, there is no comparative study between I don't debulk and I debulk. And of course, you reduce the risk of acute respiratory failure for the patient suffering from obstruction. And the vital risk of this procedure is very little. This paper by Mahmoud and colleagues in Respiration 2015 about clinical improvement in a prospective study using rigid bronchoscope. So I don't go into details, but you improve spirometry, dyspnea, and quality of life, regardless of the cause of the central airway obstruction, and with and the conclusion of the authors is that rigid bronchoscope secure airways and of course allows debulking and silicone stent placement. What I want to insist on is about that there is a difference big difference between the technical success of this procedure and the clinical benefit of that. You see the result of the American registry, and you see that the operator has deemed that in 93% of the procedure it was successful, but you see that people advocate improvement in symptoms, in quality of life, it's much less. So still, we have to really select a good indication for debulking, for this obstruction. And one of important thing about successful debulking and clinical successful debulking is the location of the tumor, of course. And again, I don't go into detail, but you see clearly that the more the obstruction is proximal, the better is the result. And it seems obvious because the more a large airway is obstructed, of course, the better there will be the improvement in symptoms. And of course, more you go distal, less you have good results. Dr. Dumont used to say that, because it's a slide of him, that it's because the tumor cannot be accessed by the rigid bronchoscope in the upper lobe. And that's very important, of course. You cannot go in the upper lobes with the rigid bronchoscope. Something important in malignancy is that if you are successful in your procedure, you give the same survival to the patient than those who have no obstruction at the same stage of the disease. That's a very important publication by, I forgot his name, sorry. He was in Switzerland, now in India. Just a quick movie to show you, because again, videos is better than words. Obstruction of the bronchus intermedius by adenocarcinoma. This is laser. You see coagulating the tumor in order to reduce the risk of bleeding during coring. So maybe you saw that laser was used more to vaporize, but in Marseille we use laser with a very little power, just to sorry, to coagulate and devascularize. And once it's achieved, you core the tumor. And that's a nice example of what you can do with the rigid bronchoscope, because you really resect big piece of tumor. You have to learn how to go in the right direction, of course, and avoid to perforate the wall. But that's it's difficult to explain. That's really clearly training. Then you remove the piece of tumor. And because this patient had the remaining compression, a stent will be placed. So a silicone stent will be placed in this patient to maintain the patency of the airway. So the stent, you see, the silicone stent is there, folded. So in this case, it is unfolded with a balloon. So you see in one video, you see how to core, how to place the silicone stent, and eventually how to deploy it. And that's very, it really brings, the yield of this procedure is very important in terms of symptoms. Again, therapeutic procedures, and I just choose one benign stenosis, which is most common, at least in Marseille, the post-intubation or post-tracheostomy. So either you have the simple stenosis without cartilaginous involvement, or a complex stenosis with cartilaginous damages. So it's a bit different because the treatment is different. But the bronchoscopy treatment is generally made before surgery. Why? Because at least 50% of the patient arrive in emergency with high dyspnea, and so it's better to at least to make one dilation before surgery. But endoscopic treatment can be definitive treatment in itself in case of surgical contraindication. and any time it provides immediate relief of symptoms and allows surgery to be done when it has to be done. So for simple stenosis, very simple, you make incisions of the web, either with laser or with scissors, and you dilate. You can do it twice or 3 times, and then you're successful.
Hervé, sorry,
yes.
You have 2 more minutes. Try to.
Sorry. And then you see,
Thank you.
on the okay, I go faster. And then on more complex stenosis, you have to dilate, but you have to place a stent. Otherwise, you have recurrence. So I don't put this movie. One very important indication is hemoptysis. So just one case, one video. So, sorry, it's because of the time of the video. So I go faster, just to show you that when bleeding occurs, and it can occur also during debulking, it's better to have a rigid bronchoscope, because you can control the bleeding with a section of the catheter, and then you can work and you can prevent flooding with just a section of the catheter. So complications of the technique. No, I would say that there is no really clear risk factor, sex, age, whatever. General anesthesia adds potential complications, but also certain degree of safety, because you're focused on your procedure, and the anesthetist is focused on the patient itself. So this is a common complications, but I am sure that you will find them on literature. So I'm sorry, I have to go faster. One complication that you have to fear is your sterilization department, but it's not on the patient, but on your instrument themselves. So when they block the door on your instruments. And so in conclusions, I would just recall you that rigid bronchoscopy is an invaluable tool in interventional bronchoscopy, and it has been stated in all this ERS, ATS, chest statement. Because with maximal safety under general anesthesia, good ventilation, good suction, you can do whatever you want, I would say, in the airway, like coring, dilation, and it's also mandatory for silicone stent placement. But it's not working for right upper disease. So the flexible bronchoscope, of course, when I speak about rigid bronchoscope, when I do rigid bronchoscopy, I always have my flexible bronchoscope inside. So because you can clear the peripheral airway, you can clean, you can work on the upper lobes. So they are complementary, rigid and flexible. So just because I realize that there is now a new indication, which is not therapeutical, which is transbronchial cryobiopsy in the diagnosis of interstitial lung disease. And in this statement, in this expert best practice, they say that it's better to do it with rigid bronchoscope or intubation. And so, like Nikos, I hope to be physically there in Athens in October. And I hope also that you will join us in Marseille. And I remind you that Marseille has been founded by Greeks for the World Congress in October again, but next year. So, Efraistopoli.
Thank you very much, Hervé, for this very organized and nice talk. And now we move on.